I am Bernard Herschel. Before my retirement, I was the chief of HIV/AIDS at the Geneva University Hospitals. You may call me an AIDS dinosaur who has followed the HIV epidemic from the very first cases in the early 1980s through the triumph of antiretroviral therapies, rarely equaled in the annals of medicine. Of course, this triumph has its flip side. Younger colleagues are no longer familiar with the opportunistic diseases and their myriad manifestations. Hence, the idea of these PowerPoint presentations transformed into videos. After a short introduction, they will show a series of images illustrating one or several exemplary cases from my files. CMV reactivates in advanced immune deficiency with CD4 counts below 50, with or without attributable symptoms. Retinitis, colitis, esophagitis are clearly recognized HIV-associated diseases. On the other hand, the existence of CMV encephalitis and pneumonitis is controversial and often difficult to establish. Highly active antiretroviral therapy has greatly diminished CMV disease, except for immune reconstitution syndrome shortly after starting treatment, as seen in the next slide. The graphs show the incidence of all AIDS-defining diseases on the left and of CMV disease on the right per 100 patient years of follow-up in the months around start of highly active antiretroviral therapy. Note how the incidence of all opportunistic diseases decreases very rapidly after starting HAART, in contrast to CMV disease, which decreases more slowly. This relatively slow decline is thought to be due to immune reconstitution syndrome, or IRIS, treated more fully in another video of this series. CMV retinitis. Here, for comparison, an image of a normal retina with the optic disc and the fovea. In this composite image, we have a peripheral lesion of CMV retinitis and, more centrally, harmless cotton wool exudates. CMV retinitis often starts in the periphery. Initial lesions are perivascular, hence the expression CMV vasculitis. The initial lesions expand and progress to necrosis. Later lesions show necrosis and hemorrhage. This lesion destroyed the fovea and of course caused an almost complete loss of vision. 3 peripheral lesions of CMV retinitis. Untreated CMV retinitis can progress very rapidly. These 2 images were taken only 1 week apart. CMV retinitis can cause inflammation of the vitreous body, partly obscuring the view of CMV vasculitis in the background. Differential diagnosis of CMV retinitis. Benign, quote, cotton wool, unquote, exudates are frequent in HIV positives, but they are not specific to HIV infection because they are often seen in other conditions such as diabetes and hypertension. Toxoplasmosis in advanced HIV infection is mostly about brain abscesses, but it can also involve the retina. These lesions are usually unique, but their aspect can be undistinguishable from CMV retinitis. Here is an example in an HIV negative patient before and after treatment. Miliary chorioretinitis, here due to tuberculosis, can also be due to candidemia, disseminated toxoplasmosis, PCP, and possibly syphilis. Chorioretinitis in a case of disseminated pneumocystis infection. This patient was extremely immunosuppressed with hardly any CD4 cells left. For prevention of PCP, he inhaled pentamidine monthly. In HIV negative patients, particularly in those on parenteral nutrition, but not in HIV positive patients, candidemia may involve the retina and causing whitish lesions as seen in these two photographs. Chorioretinitis due to syphilis. This lesion involved the fovea and caused marked loss of vision, but vision recovered after treatment with penicillin. CMV involvement of the gastrointestinal tract. As seen here, CMV typically causes longitudinal ulcers in the esophagus. Another view of the typical longitudinal ulcers caused by CMV esophagitis, here in an autopsy preparation. A prominent eosinophilic nucleolus, here in the submucosa of the esophagus of the previous case, is evidence for CMV infection. A liver biopsy with numerous viral inclusion bodies. If it's CMV, these have traditionally been compared to an owl's eyes. A 7-month-old baby congenitally HIV infected with diarrhea. The image on the left shows mucus, stool, and bright red blood with clots. The patient died, and at autopsy, ulcerations of the GI tract and inflammation with cytopathic cells suggestive of CMV left insert. This suspicion was confirmed by antibody staining, right insert. A case study of CMV colitis of a 51-year-old man with multi-resistant HIV infection and oropharyngeal candidiasis on fluconazole and cotrimoxazole prophylaxis. He had moderate diarrhea 3 times daily, with weight loss of 3 kilograms in 3 weeks and increasing abdominal pain and cramps. He was admitted for workup. He was subfebrile, had pancytopenia with a hemoglobin of 118, white blood cells 1.6, platelets 100. The CRP was elevated, as was the LDH and also the liver enzymes. He had 4+ proteinuria with a normal creatinine. The CMV viremia was positive at 4,000 copies per ml, and a bronchoalveolar lavage also showed CMV. The results of the proctoscopy, the biopsy, and the abdominal CT scan are shown on the next slide. The CT scan showed thickening of the transverse and descending sigmoid colon, see arrows. Probably the bladder was also involved with wall thickening. The proctoscopy showed inflammation with ulcerations. CMV infection was confirmed by the rectal biopsy, which showed numerous viral inclusion bodies and positive staining with anti-CMV antibodies. He was treated with ganciclovir 5 milligrams per kilogram IV twice daily, had improvement in abdominal pain, the proteinuria disappeared. The patient survived and eventually did very well with integrase inhibitor treatment. Apart from retinitis and gastrointestinal involvement, the CMV infection in the HIV has many other possible manifestations, which however are less tightly linked to CMV than the first mentioned. An example is involvement of the central nervous system. On the left, we have a CT scan of a man with cerebral toxoplasmosis, but in addition, periventricular enhancement by gadolinium is seen, which is said to be suggestive of CMV encephalitis. On the right are two pictures of the brain at autopsy with prominent inclusion bodies due to CMV. Treatment of CMV infections in AIDS relies mostly on ganciclovir, given for high doses during 3 weeks, then half doses. It has an essential side effect, which is leukopenia, and dosages must be adapted to the renal function. In case of resistance and/or intolerance, there is foscarnet and maribavir. It is also very important to initiate HART. Treatment can be stopped once CD4 cells exceed 100 per microliter. In cases of early treatment, the response can be very gratifying, as seen in these two pictures. However, when treatment is late, extensive scarring may produce permanent loss of vision. Here is another before and after picture of Cytomegalovirus retinitis treated with ganciclovir. On the left, note involvement of the fovea, producing marked loss of vision, and the granular appearance of the retinal infiltrates along the inferior border of the lesion, which is typical for CMV retinitis. On the right, 1.5 years after treatment with intravenous and intravitreal ganciclovir, the lesion became an inactive scar, but vision remained poor due to involvement of the fovea. As always in advanced HIV infection, CMV disease does not exist in a vacuum and coexists with other opportunistic infection. Here's an example of a patient admitted to the ICU with respiratory failure due to disseminated histoplasmosis. Once he was extubated, he complained of loss of vision on March 4, 2003. With ganciclovir treatment, he recovered most of his visual acuity, June 3, 2003. In patients who are unable to tolerate systemic ganciclovir, local treatment by injection or implant can be tried, as shown here. Thank you for watching, and thanks in particular to Drs. Balivo and Siri Santana for their contributions. This video is part of a series on opportunistic infections in AIDS. I'd be grateful for any feedback that you might have, and if you are interested, please subscribe.